Yes.
Okay. Okay. So welcome everybody to the ACNS IVR Fujita web seminar today. We have two speakers today, Professor Wataro Tsuruta from the Toranomon Hospital, Japan. He'll be talking about aneurysm, coiling and FT. And the second speaker is Professor Ittichai Sakarunchai from Bangkok, Thailand. We'll be talking about complex aneurysm and endovascular treatment. We have Prof. Yoko Kato to chair this meeting, and we have discussants in the form of Professor Mynzhykly Berdikhojayev from Kazakhstan and also Professor Nagoya who will be joining us soon. So first of all, I would like to invite our Honorable Chair, Professor Yoko Kato, to give her opening remarks.
Okay, thank you so much. So both Tsuruta Sensei and also Ittichai is an expert for the endovascular treatment, I think. So maybe we can learn many things from two of them. Especially I think aneurysm treatment is very attractive for all of us. So let's start. Please.
Yes.
So my Sensei,
Yes,
please.
Tsuruta Sensei, please start.
Okay. Yes. Now I'm sharing. Can you see my
Yes.
slide? No?
Not
Yes.
yet. Not yet.
Desktop. Okay. Yes.
Yes.
Yes. Can you see?
Yes, it's okay.
Yes.
Yes. Okay. Let's start. Today's my topic is aneurysm coiling and flow diverter. And today's my talk is focusing on basic aspect for beginners. So please listen in relaxed manner. Let's start. Coil embolization is composed of microcatheterization and coil insertion. Framing coil, filling, finishing coils are inserted into the aneurysm step by step. And vascular obliteration, And vascular obliteration of aneurysmal flow is the concept of this treatment. And the stability of microcatheter is very important. When the tip of microcatheter is here against the aneurysmal wall, it carries risk of aneurysmal rupture or easily kicked out of the aneurysm. So tip of microcatheter should be around the center or proximal 1/3. And we have various pre-shaped catheter, and we can also make favorite shape by steaming. And as for microcatheterization, or when the microcatheter can advance without any sticking in the vessel, while leading method is simple. But sometimes catheter are sticking in the vessel due to vessel toxicity. In such a situation, catheter pullback method is better, safer. And working projections are very important, and left one is good working projection, but right one is not good. Working projection is the view we can judge a borderline between aneurysmal neck and parent artery. And right one is not good because we cannot judge whether this coil part is in the aneurysm or in the parent artery. So left one is good. In the real world, working projection, left one is good, and the right one is not good. Double shadow, we can see. It is not good. And as for coil selection, or for framing coil, we usually select average diameter of XYZ. And we usually use 3D shape for framing coils and the helical shape for filling and finishing coils sometimes. And also, we usually use 3D shape for filling and finish also. And this framing coil is undersized coil section. We can see some space between coil mass and the aneurysmal wall. And the final angiogram demonstrating some space between coil mass and the aneurysmal wall. It carries risk of recanalization, not good. And this case, very good site selection, and this is final angiogram. We cannot see any space between coil mass and aneurysmal wall, complete obliteration. This is very good. And how many coils are needed for adequate embolization? Volume embolization ratio is a good index for setting goal. When you put lambda centimeter of 0.010 inch coils, 10 coils into the aneurysm, VER is calculated by this formula. And more than, I think 30% is adequate embolization. And coil loops movement is different according to catheter position. When the tip is center, in this situation, coil loops spread concentrically, and dome position, deeper position, coil loops come back to neck. On the other hand, at neck position, coil loops go into deeper side, to dome. So we can control coil loops movement by catheter maneuver. Sorry, this case. This is a MCA unruptured wide neck type, and catheter is here, neck position, out of the neck position, and coil loops go into the aneurysm. So I could insert coils without any adjunctive technique, like this. But in wide neck case, irregular shape, large type, these are difficult to treat with simple coil insertion. So we need to use adjunctive technique for coil embolization, such as balloon-assisted, double catheter, and stent-assisted coil embolization, including flow divert. This is paraclinoid aneurysm and a little bit wide neck, and this is balloon assist. And with neck sealing by balloon, we can insert coils without any protrusion. And balloon can contribute to stability of catheter position, catheter support. This is also useful effect of balloon. And the final angiogram demonstrating complete obliteration. And this is a clover-like multilobular aneurysm. It's very difficult. So we used double catheter technique. And two microcatheters in each part of the lobula. And first Fleming coil was formed in the aneurysm, but still unstable. So before detachment of the first coil, I inserted the second coil from the other catheter, like this. And now Fleming coil was firm, stable frame with two coils, and detached. Then filling and finishing coils are inserted, and finally achieved almost complete obliteration. So the most important benefit of double catheter technique is we can decide detach the first coil or not after two coils insertion. This is very important thing. And this is intracranial stent, and intracranial stent is divided into two types: braided stent and laser cut stent. Braided stent is such as Elvis Blue and flow diverter. And braided stent is made of wire mesh, and it has higher metal coverage rate, so flow diversion effect is expected. But sometimes positioning and deployment is difficult because shortening will occur. And on the other hand, laser cut stent, new from Atlas Enterprise 2, these are made of metal pipe and low metal coverage rate, but easy to use. Positioning and deployment is very easy, and nice vessel conformability. So we will better use each braided stent and laser cut stent in each situation properly. This is a common ruptured wide neck aneurysm, and coils were inserted with double catheter technique, and incidentally, one coil loops were protruded to left A2. So I use Neuroform Atlas. This stent is a laser cut stent and very soft and good conformability to the vessel wall, and nicely recovered. The coil loops recovered into the aneurysm, and good conformability without any complication. Complete oversight follow-up angiogram demonstrating complete, but just after the treatment, body feeling. And this is left cavernous large aneurysm in the floor diameter case. And when we use floor diameter, catheter support is very important. So usually we use triple coaxial system. And guiding sheath, 6 French guiding sheath is the lower part we cannot see. 6 French Fubuki, and now here is the 5 French Navien. Nowadays I use 4.2 Phenom Plus and microcatheter for delivery of product. This is triple coaxial system. And deployment technique is three types. And one's unsheath deployment by pulling microcatheter, and wire push is deployment by pushing delivery wire. And system push and pull is that whole system push and pull. These 3 actions I use when to deploy. Okay, and this is one case. Cavernous portion, cavernous aneurysm case. And at first, I start deployment of the floor diameter in the M1 straight position, and I check the good opening of the distal end, and carefully pull down to the appropriate position, very carefully, very slowly, and now appropriate position. So I deploy by wire push. And now we can see flattening, a little bit twisting. So too much force on the blade. So I do system pull and nicely now opening. And then a combination of wire push 70% and unsheath 30%. Then finally, for that pipeline was nicely deployed like this. This is different case, and I'll show you tips of deployment or in Porteous siphon curve. Please look. We can see too much force on the blades, and this is flattening. Then I advance diameter, advance longer. Then repeat system push and pull. Then open. Now I advance floor diameter longer, and repeat wire push, system push and system pull. Sorry, again. This is now flattening. Then I advance deployment of floor diameter longer. Then system push and pull. Repeat system push and pull. Then open like this. Okay. These are tips of deployment of in a Porteous siphon curve. And this is Conbeam CT and a good position I can see. And 1 year follow-up angiogram demonstrating complete obliteration like this. OKMD. Yes. And this was showing peri-procedural thrombotic therapy for aneurysmal embolization. When we treat unruptured aneurysm, dual antiplatelet therapy for more than 2 weeks before the procedure, and intra-procedural systematic heparinization. And in the rupture case, we do only intra-procedural systematic heparinization just after cyst introduction. And in the case of stent-assisted coil and the flow diverter, we continue dual antiplatelet therapy for 6 months, followed by single antiplatelet therapy for 1 year after aneurysmal obliteration. And this is final topic. What should we do? And bail out of intraprocedural rupture, please notice the fact. And don't pull back the coil and catheter because the perforation hole is closed by catheter or wire. So when you pull them back, the hole is open and extravasation will occur. So don't pull back. And the first thing you should do is blood pressure control. And if balloon catheter is around the neck, balloon inflation across the neck. And if you cannot get hemostasis, protamine reversal is needed. And you do further coiling insertion. And you insert coil loops out of the aneurysm in the subarachnoid space, and then come back to the intra-aneurysmal space. And the hole is sandwiched with coil mass. Okay, I'll show you one case. This is unruptured ACOM aneurysm, very irregular shape, so high-risk case. And I treated it stent-assisted coil embolization, uniform atlas. And first coil is good, no problem. Then second coil, and this catheter cannot kicked out because jailed by uniform atlas. That now perforation, the extravasation. Then I insert further coil insertion very fastly. This is subarachnoid space. And now balloon catheter coming, and I inflate the balloon at the top of IC top. Then further coil insertion out of the aneurysm very fastly, and come back to inside of aneurysm, and that perforation hole is sandwiched, and hemostasis was achieved like this. This is a troubleshooting. Okay, these are essential points of aneurysmal coiling. Peri-procedural antiplatelet therapy, appropriate working projection for neck detection, and the microcatheter stability and appropriate coil selection, microcatheter maneuver for coil loops control, and application of adjunctive techniques and bailout. And this is very important of aneurysmal rupture and sometimes promise formation. And points of flow diverter, a good support of guiding system. This is very important. And proper site selection also important, and good standard position, appropriate antiplatelet therapy. Thank you very much.
Thank you. We can invite our discussants, Dr. Mynzhykly. Dr. Mynzhykly, can you hear us?
Yes, thank you. Good evening, Professor Yoko, Kato, and colleagues, and Wataro, Tsuruta. I hope I'm correct in spelling your name.
Wataro, Tsuruta, yes.
It's a great and yes, it's a great presentation from basics to the advanced treatment, and
yes,
it's a very nice explanation
very basic.
of the coil. Yes, the coiling and the coil size correct chosen, and the position of the microcatheter, it's very nicely described, and I think for the young physicians it's very important, because nowadays everywhere is flow diverters, and coiling is still there, and in ruptured cases, in simple cases, simple coiling or balloon or stent-assist coiling is very important, and it's quite cheap technique. And as I noticed, you still use coils in small aneurysm, in ICA, in ophthalmic segment supraclinoid, and nowadays we use more and more flow diverter stent. It's quite easy to deploy, but in long term, it could be problematic because of fish mousing, stent thrombosis. In some cases, simple coiling is very important. And from my point of view, in a case of intraprocedural coil perforation, we used several times liquid embolic injections through the microcatheter, but in our department, we use DEMSO compatible microcatheters, which is Echelon, Headway 17, or similar microcatheters. It's possible to inject dimethyl sulfoxide DMSO and apply squid 12 or 34 to seal the hole on the wall of the aneurysm. In some cases, I noticed coil sometimes is not so effective, and the blood leakage is continuing with the massive subarachnoid hemorrhage. That's why we are injecting liquid embolic.
You mean
Yes,
you
and
use
that's
Onyx liquid embolization in the situation of
yes, yes.
interprocedural rupture? Really?
Intraprocedural rupture.
So you inject
Yes.
liquid embolization, liquid material in the aneurysm.
In
You
aneurysm, yes.
navigate microcatheter into the aneurysm rapidly,
With the
such as
same micro coiling catheter. With the same coiling.
Okay, so usually
Yes.
you use DMSO compatible catheter for aneurysmal embolization, such as Headway, dual Headway or Echelon.
Yes.
Marathon is also. Thank you.
Yeah, then it's very effective, and we use several times, and there is already risk of parent artery occlusion, but with a nice angio machine, usually it's very safe.
You can control that liquid embolization movement. You use balloon. You use balloon for neck sealing when you inject Onyx or liquid embolization.
Yes, most of the time we are doing balloon assist coiling. That's why balloon all the time in place, and it's very easy to just inflate the balloon to stop the to flow arrest, and then inject the liquid embolic inside the aneurysm.
Oh,
Yes.
okay.
Then it's
Thank you.
in safe manner.
Okay. Thank you very much.
Thank you. Thank you.
Thank you. If there are any further questions, I would like to ask Professor Tsuruta, what about the further surveillance after the person has undergone successful coiling? How would you call for follow-up this patient?
Follow-up.
Yes.
Usually, I check by MRI every half a year, every 6 months, and after 1 year after the treatment embolization, usually I do angiography and check the obliteration of the aneurysm, routinely 1 year follow-up angiogram, and other evaluation is performed by MRI every 6 months or later every 1 year.
Okay. And also, once you have put the flow diverter, what is your anticoagulation policy? How do you give antiplatelet?
Yes, usually I start dual antiplatelet therapy at least 3 weeks before the treatment, because sometimes I encounter delayed conversion case, and PRU is decreasing gradually, for 1 month. So I start 3 weeks or 4 weeks before the treatment, and after treatment, dual antiplatelet therapy for 6 months routinely. And in fraud avatar case, we do angiography after 6 months follow-up and 1 year follow-up. So, and we check 6 months follow-up angiogram. Then I change to Sept, single antiplatelet, and it will continue several months. And when we checked complete obliteration, the aneurysm, we can stop the all antiplatelet therapy, I think.
Thank you very much. You can invite comments from Prof. Kato.
No, it's okay, fine. So I think it's quite new for me because coil plus liquid material. So Tsuruta sensei, is it kind of popular in Japan?
Yeah, not popular. We are aware of migration of embolic material to the distal embolic complication. So usually we don't do. And in my experience, coil embolization sandwich technique is usually enough. No. But sometimes neck laceration in such a situation, further coil insertion is not effective. So in such a critical situation, liquid embolization might be effective.
Okay, thanks so much. Excellent talk. Thanks so much, Professor Tsuruta sensei.
Thank you very much, Professor Tsuruta. That was very excellent lecture. We learned a lot today. Thank you very much. So now we'll move on to our second speaker, and I will invite Professor Ittichai to give his esteemed lecture.
Okay, can you hear my voice?
Yes, we can.
Yes. Good evening, everyone. First, I would like to sincerely thank Professor Yoko Kato for giving me a chance to present today. And my talk today is the endovascular treatment for the complex cerebral aneurysm. I focus on the current strategy and simple approach, maybe just a bit different from Professor Tsuruta, because I concerned about the antiplatelet therapy in the rupture case. But today I will show to all of you how about my strategy of the treatment. And my hospital is working in the center of Bangkok, Thailand. It's close to Chao Phraya River. And in my country, most aneurysm presentation after rupture case, almost the case is a rupture case. This means subarachnoid hemorrhage is often the first clinical presentation. This is a serious and life-threatening condition that's demand timely to treat this condition. For the definition of the complex cerebral aneurysm is not based only the morphology of aneurysm, but it also depends on about the site and the neck characteristic, about the risk of breathing, the high recurrent rate, and the technique difficulty for treatment. Why modern devices are designed to achieve the treatment successfully, but the simple techniques may be just only coiling without any assisting device maybe this is a high variable and safe for the patients. Therefore, we must evaluate the risk and the benefits for treatment of the rupture case. So the treatment philosophy in my mind, I just need only the simple techniques to treat in the rupture ones, because this is the safest result of the patients. Just that debates on the risk re-rupture after treatment, this is very important because in some situations, we cannot understand the natural history of aneurysms. Even we already successfully treatment, but the re-rupture will happen again after the treatment. So the coiling alone is very best options because this option we don't need to have the antiplatelet therapy and it's not disturbed about the hemodynamics of the aneurysms. And for diverters, okay, it's very good and challenging technique, but we need to prescribe the dual antiplatelet. This is not good for some elderly patients or some like a clinical worsening in some patients, because we concern in many times, and also the flow diverters can change about the flow dynamics of aneurysm. It can be have a re-rupture again after we put the flow diverter in the precise location or an eventful after treatment. So the first line of the treatment by flow diverter in the rupture case, I not recommend in some cases. This is the case presentation of the female in the 84 years old. She presented with a dizziness and neck pain. The CT scan show diffuse sublunar hemorrhage in the basal cistern and predominate in the left side. And the 3D angiography reveal this big PCOM aneurysm that have involved about the PCOM and very wide neck of aneurysm. And also, this case have the PCOM originate from the wall of aneurysms, and another aneurysm in the ventral side, it have a small aneurysm. But I believe the rupture point is the bigger one. How we can decide about the option of treatment in the rupture case like this is may difficult to discuss with the family of the patients. How about the risk and complication of treatment? This one that show the big PCOM arise from the dome of aneurysm. How we can preserve this vessel and we can occlude about the rupture point in the same time. This is a difficult resolution in these patients. We just put one flow diverter. This is enough. I am not sure. Or we need to stent assisted coil embolization. Maybe we cannot preserve in the PCOM. Or we just use double microcatheter technique to assist that coil embolization. Or we use the balloon assist coil embolization. For my mind, at that time that I mentioned before, I need to do the simple technique first without any assistant device at the first time, because I don't like to give antiplatelet at that time. So I use the double microcatheter techniques, two microcatheter together to put the first coil framings and the second coil to against the force to the wall of aneurysms. And we can slowly adjust the second coil in the first coil. That means it can be stabilized about the coil loop together, and it can stay in the aneurysm sac only. It's not protrude in the parent artery. And you can modify interchange between two microcatheters together, and you can lock about the frame roof at that time until it's stable, and you can pack more dents in the aneurysm sacs. And you can make sure the dense packing in the rupture point or not. So I try to pack more of the coil in the ventral part of the aneurysm sac like this, because I want to guarantee or make sure it can obliterate sufficiency. And the control angiography show, okay, it's good for coil embolization to occlude in the rupture point and without occluded in the PCOM. You can see this is the pattern of the PCOM. And the 3D angiography, okay, is some residual aneurysm, but I am satisfied at that time that we can use only simple coil to pack above the rupture point. After the patient have recovered from the critical in the life-threatening period, I just have like a schedule for next 2 months to put another 4 diverters. At that time, then I can give dual antiplatelet, like can make sure it's not like have some problem similar in the acute periods. And the second cases, this is a 50-year-old male. He presented acute onset headache. At that time, the CT scan showed the diffuse sublingual hemorrhage. And this is a very amazing configuration of the ACOM aneurysm. You can see it have like a bilobe of the aneurysm, have share the neck together. It's a wide neck of the ACOM aneurysms. This is a 3D. You can show they have the upper lobe and the lower lobe of the ACOM aneurysm. But in the upper lobe, maybe the rupture one because irregular shape and irregular wall of aneurysm. And this is similar to the Mickey Mouse ear appearance. And the size is a 2.7 by 2.3 is the upper one, and the lower one is 2.4 and 2.3. It's a bit difficult, but at the first target, I want to secure at the upper lobe first because I think it's the point of rupture. But in the working projection, the microcat and micro-Y is really difficult due to the limitation of the curve to put in the upper one. So I continue to coil in the lower part first because it's really stable of the catheters. I just put more about the coil to make a dent packing of the aneurysm in the lower part or the lower lobe. But for the catheters, after I occlude the lower part, I try to go in the upper part or the upper lobe. But the catheter is very difficult microcatheter cannot follow to more deep to the aneurysm sac. It just only in the neck of aneurysm. This is not enough for stabilize of the microcatheter. But at the time, I do not force too much because I afraid to rupture one during selection. I just use the conventional 3D coil, but it cannot like a place in the aneurysm sac at that time because you can see about the obstruction of the neck at that time and the microcatheter not stable. I change the very extra smooth the coil, but the location of the microcatheter is at the same. And I just put more coil, the second coil, and the third coil, like this, until I can pack more. And make sure I can prevent the re-rupture of the both lobe of aneurysm. So I can pick more one, and the angiography after coil embolization, okay, it can complete the aneurysm obliteration, but you can see it's remaining of the neck of aneurysm because some limitations of the coil. Okay, I will follow if the neck can progress about the sizing. I will retreatment again. And the third case, this is a very old patient, 78-year-old female present with alteration of consciousness. You can see about the diffuse sublunar hemorrhage and the CTA review the Vinex of the left SCA origin aneurysm. This one. This is a 3D, how you can put the coil in the sac and preserve above the parent artery of the SCA. It looks like it's not difficult, but in the real situation, it's not too easy because you need to control about the catheter, allow the neck. It's not can to go to more deep because the coil cannot stabilize above the aneurysm sac during embolization. And I try very many times how to pack it adequately and preserve the SCA. And finally, I can the control about the microcatheter in the outside of the neck, and the coil is very stable and can embolize in the sac like this. And the finals of angiography, you can see I can pack more leads in the aneurysm sac. And control angiography is quite good. You can preserve, but unfortunately, a misinterpretation in sometimes can happen. The actual or the point of rupture should be in the PCOM instead. So I looking in the PCOM, you can see this is a foul sex of aneurysm. So I need to treat in the left PCOM again. At that time, where patient very old and they have tortuosity of the ICA due to atherosclerotic change. So the first coil frame is seem like to be fine. And the angiography, after I put only framing coil at the first time, the first coil is like to be okay. But during I manipulate the second coil to feel it can put the first coil out to the parent artery. The coil protrudes in the parent artery like this. How can I do at that time? Just leave it in the parent artery or use the stent to trap the coil in the parent vessel. Three is I will share again, sorry. Yes, I just use the stent retrieval to retrieve it from the protrusive coil, and this one I deploy the stent retrieval past to the coil roof like this. And this one, you can see I just deploy stent and I retrieve the coil that's protruded in the vessel to come down in the intermediate guiding catheters. And at that time, the aneurysm still fine in this area. So I just changed strategy to shoot another configuration of the coil. It can successful to stabilize in the aneurysm sac. The patient recovery well. Yeah, this is the last case that I want to show about my strategy. This is a bilateral MCA bifurcation aneurysm in the right side and in the left side. In the right side, it's about 3.7 millimeter. In the left side, about 3.1 millimeters. Okay, in the left side, I just treat only simple coil. It's no problem. But in the right side, because it's wide next of the right MCA bifurcation, I just use the technique for the double microcatheter technique. It can complete aneurysm obliteration in the two sides in the same time. In only one time, I can finish two procedures of both sides. So for my conclusion, the treatment of the complex aneurysm is require the case-specific strategy, and the rupture one, we should the embolize in the simplest techniques because the result should be the safe to the patients. Because I concerned about if I use in adjunctive device like a stent or balloon, we need to give more antiplatelet or heparinization. Maybe complication can occur. So we need to balance about innovative device and the simplest technique to treat in the complex rupture aneurysm. Thank you.
Thank you very much, Ittichai. It was wonderful. Prof. Mynzhykly.
Yes, very nice talk, Ittichai. Yes, simple coiling. It's looked like simple, but in my practice, I learned from my teachers, and usually they start to teach us how to use balloon assistance. And in emergency cases, when you do coiling, the balloon assistance is not only about the reconstruction, remodeling, but it's all the time about safety. And in the case of possible coil migration, nowadays with balloon, you can just arrest the flow and reposition your coiling catheter, and it's also possible to open the stent and do the stent assistance. Not all balloons is double lumen. We still use single lumen hyperglide balloon, and with the coiling catheter, at the same time, we can replace distally, and it's possible to open laser cut stent like Neuroform Atlas, Aclino, Flex, Credo, or Pegasus stents. And it's a laser cut stent. You can just resheet the stent and then deflate the balloon, and you can fix the start to migrate coils. But it's very nice technique of coil ectomy. Thank you for sharing. The solitaire or any kind of stent retrievers is very effective when you plan to do coil extraction. And in our cases, when we see on CT angiography wide neck aneurysm in ruptured patient, we preload the patient with the ticagrelor, which is Brilinta. Patient in emergency room receive 180 milligram of Brilinta and 500 milligram of aspirin if there is no hematoma. If there is no parenchymal hematoma, then in simple SAH patient, it's possible to prepare a patient for possible stent assistance, but we try to do balloon assistance as much as possible. If it's not possible, then we can open the stent, and usually those stents are with the surface modification, like a Pegasus HPC, Credo Heel, or other, like a pipeline shield, and then we are little bit in a safer condition with the surface modification. Yes, but the simple coiling is best technique, and I have seen the new robot for the microcatheter tip modification. The robot came from Chinese colleagues, and the cost of the robot is a little bit costly. It's easier and cheaper to pre-shape with the teapot. Yes, it's cheaper, but our colleagues designed with a 3D printed vessel model, preoperative microcatheter tip modification. I think there is some rationale, but the machine is a little bit costly. Thank you for sharing your experience, and I think it's very important to do and to know how to do the simple coiling. Thank you.
Thank you.
Thank you. Thank you, Prof. Mynzhykly. We can take comments if there are any from the panelists. Professor Kato, would you like to say something? You are on mute. Please, can you unmute your mic, Sensei?
Right. Maybe we can ask Dr. Tsuruta Sensei and also the guy from Indonesia.
First, we'll take comments from Tsuruta Sensei.
Yes, very nice presentation. Thank you very much. And we saw many small cases, small rupture case. So I think, of course, a balloon is very useful and can get hemostasis, and sometimes neck sealing. Balloon assist is very useful for rupture case. And also, I think microcatheter modification, microcatheter shaping is very important. And when we do simple technique or double microcatheter technique, catheter shaping is very important. And usually I use headway microcatheter because a good memory shape, and we can modify very easily my favorite shape. So what kind of microcatheter you use is very important. How about you? What kind of microcatheter usually use?
Thank you, Professor. This is a very good question. So I usually use two kind of the company. The first one, Headway. Yeah, I use Headway Advanced, and another one is a SL10 from the Striker.
Yes. Yeah.
Because the marker of the both of them is a difference, so I can recognition which one I manipulate first. And the good quality that you mentioned before of the headway is really soft and a good memory curve, so it's really easy to adjust about the movement of the tip of the microcatheter. This is it's a good one.
Thank you. But I think SL10 is softer than headway. Do you think? I think headway is a very good memory shape, but a little
It's
bit
hard.
So usually I use headway for unruptured case. Of course, I use for ruptured case, but very unstable situation, and sometimes tip is against the wall. In that situation, headway is a little bit stiff, so I prefer to use SL10. More softer, yes, SL10. So I use each catheter properly in different situation, in each situation. Thank you very much.
Thank you.
Thank you very much. Itti, I would like to ask, there are few people in different parts, like who for an acute rupture, they take in the patient and do a DSA and insert some coils in the beginning to get a hemostasis, and they come back later after 48 hours to do the definitive coiling. So what do you think about this?
You mean the separate two procedure for treatment of the patient, right?
Yes. In an acute phase and after 48 hours.
Yeah, this is the good for treatment that I mentioned before, because we don't like to disturb about the hemodynamics of the brain at the emergency time, because the brain swelling, vasospasm, something like that. If we treat the state of the treatment at the first time, just only put the coil to protect about the rupture point. Yeah, but you should put it more enough. It's not loose, just tight, but you can have some residual aneurysm. Is okay, but it's not too much. Then you bring the patient again, maybe one week or 2 weeks. You can definitely treat totally. It's okay in some situation, but in some the blister case, blister aneurysm, you should finish at the one time, because it's a very high risk for re-rupture. When you treat at the first time, you should definitely in only one time.
Okay, thank you. Yes, Kusuma, would you like to say something?
Thank you so much for the chance. Thank you so much, Professor Ittichai, for the great presentation. I have questions. So in the third case, it was mentioned that the coil was flipped out of the target. What was the patient's outcome, and did everything turn out fine, or was there a risk of other complication because of it? And then the second question is, what are there any limitation to the simple coiling technique that you present, and how can this limitation can be managed to prevent any complication because of the limitation? Thank you.
Yeah, thank you for your question. At the first question for the third patient, that the coil protruded in the parent artery or the ICA. After we retrieve it and just coiling again, the patient no complication, and the clinical is very good, like a good recovery. But you should be careful during you decided your treatment like this, you should just choose the kind of stent retrieval. In some professor, they recommended you use like the stent design that is the cross design that like a sheet, because when it retrieve the coil, the stent can remove like this and pull out the coil. But in some stent have the very rigid, just only the start like a pull up, maybe the coil may be injured about the neck of aneurysm, maybe perforation. So just only like a smooth, gentle, and like a have the team about the thing together, which the best instrument or device we can choose at that time. This is the first question. And the second question, the limitation of the simple coil, that one is a very wide neck of aneurysm. The wide neck or the shallow neck or shallow dome of aneurysm, maybe we cannot finish or the treat patient by only simple coil. Even the double microcatheter is cannot treat. We need to only use the balloon or use the stent to assist the embolization. But we have just only have the one plan, the first plan, second plan, third plan. Which one is the best for the patient? Yeah, and we need the well-trained, like try to study more. How about the configuration of the aneurysm dome, the position of the aneurysm neck, and how about the substance of the coil that you use in every day. So you will know the manner of the coil, manner of the catheter. You will know about you can move very fine movement or very quick movement. That means you can hold the situation by yourself. This is my strategy. Need to train and need to the time, need to have a small case to study. Thank you.
Thank you very much, Professor.
Thank you, Ittichai, for this wonderful lecture. We learned a lot. So now we have come to the concluding part. We'll hear the final remarks from Professor Kato.
I want to ask Ittichai, thank you very much for excellent talk, as always. So I think in the future, I think the treatment of the aneurysms, of course, are simple and faster, and also the less complication. Recently, we at our institution, the less chance to use the coil. I don't know the details, but what about the coil perforation? And sometimes, of course, the coil compaction or recanalization rate. Of course, you are expert, so maybe you know the disadvantage the coil thing. I would ask, of course, the coil disadvantage and also the future your plan. Of course, the coil is the most simplest, I think. But maybe so many companies products and so many nicer devices. What do you think about? No, I'm asking Dr. Ichi.
Yes, I thank you for your idea, Professor. Yes, nowadays many companies have like a competition to compare about the advantage of the many device to like a compete occlusion, less recurrent, less complication, like no need like a anti-platelet in some time because the surface modification in flow diverter, but just only in study. Now no one company can use it standalone without any medication, and some device that they they approve, okay, this is the best one, but finally they have like a stop to study because some complication can occur in some series. They will change the product maybe in every year. So the strategy of treatment, I think the simple technique is the best, but in some situation, just only selected case cannot suitable for simple treatment, simple technique. We need to assist device also. But I just want to concern if we study and we follow in the some. It's not too difficult, but we need to use the assist device in every case. I think it's maybe in some cases it's not good for the patient. This is my idea, Professor.
Thanks so much, Iti.
Professor Mynzhykly has raised his hand.
Yeah.
Yes, Prof. Mynzhykly?
Yes, the small comment. We are talking about the angiographic images, but behind of these angiographic images, biology and anatomy of the patient. And at the time of rupture, usually the aneurysm is thrombosed, sometimes is inflamed, and it's very active process. And we are placing the coils inside the biological structure, and the aneurysm could be dissected, and your coil will be compacted on the next angiography. In the case of blister aneurysm, it's just a tear on the wall of the artery. And I think it's very complex to compare the material. It's very important, the biological part also too. And in the case of ruptured aneurysms, it might be some thrombus inside the aneurysm, and after coiling, the thromb can be resorted, and it would like a small coil inside the big aneurysm. And I think it's not comparable, the clipping cases with the coiling cases. In clipping, we're acting from outside of the aneurysm, and we see the wall of the artery. And even with clipping, in long-term follow-up, the artery is changing because the flow in the artery is not changed. The anatomy is the same. And in the case of inflammation on the wall of the artery, the aneurysm will come back, could come back. And I think it's very dynamic process. And with the new tools, yes, the intrasaccular devices looks like promising, but in long-term follow-up, the stable occlusion is not more than 80%. And adjunctive stenting is increasing the long-term follow-up effect. And about the present situation, the new coils from Chinese companies and worldwide are coming, but it's very past. It's just the beginning of the coil manufacturing. It's the bare metal coil. We are talking about the 90s, but new coils is not even coming. I think it's need more innovation to look after. And there is also innovation in intra-aneurysmal coagulation. The new wires is coming. I think there is something new will be in next 5 years. And it's not just about the coil placement. It will be about the coagulation of the aneurysm from inside. In microsurgery, you coagulate from outside, and in blister aneurysm, in microaneurysm, it's just possible to coagulate the dome of the aneurysm, and it's end of the treatment. And I think in the near future, the coagulating wires will be available, and it will little bit modify the treatment strategy. Thank you.
Thank you. Thank you very much, Professor Mynzhykly. If you go back to the history of aneurysms, the earliest treatment of aneurysms recorded was a stereotactically placed electrothrombosis. So as you said, the coagulation may come in future. We are going to the around, coming all the way around from outside to inside. Thank you very much for your comment. So can we have the closing remarks, Sensei?
Well, thank you very much for the Tsuruta Sensei and Dr. Ittichai. Both of them are very excellent. Especially Tsuruta Sensei talk is good for the YNS. Of course, Ittichai is also, I think. So now it's a time or era of the endovascular treatment. So I'm open surgeon, but now it's so many cases we can give the endovascular team now. So it's getting less and less of the open surgery now. And I think through our discussion, we can get the new knowledge from each side. Thank you so much. It was wonderful. Yes, webinar. Thanks so much.
So thank you very much. Now we have come to the end. We have come to the end of this webinar. Thank you very much for all of you joining, and thank you for teaching us Wataro Tsuruta Sensei and Ittichai Sensei. Thank you. Bye bye. See you later.
Bye bye. Thank
Arigato.
you.
Bye bye.
Arigato.
Arigato.